The screen?
Yes, please. Present.
Yeah, so very good morning to all of you. At the outset, I'd like to thank the organizing, can I go ahead with this one first, Dr. Diti, or?
Sure. No problem. You can hold it.
So at the outset, I'd like to thank the organizing committee for this opportunity. So this is one of my first talks. It's the management of suction loss during small incision lenticule extraction. I have no financial disclosure. Now, although the incidence of suction loss in SMILE is very low, nonetheless, it is an important complication that warrants a proper management. The duration of the laser pass is longer vis-a-vis the femtosecond LASIK. Also, the dock here is softer and it's a corneal dock, which may be some of the predisposing factors for an increased incidence of suction loss. Now, in all the stages of suction loss, we can proceed with a SMILE procedure in the same sitting with certain alterations in the parameters. The only exception is when more than 10% of the posterior lenticule cut, which is the refractive cut, is complete, wherein one has to convert to a femtosecond LASIK. So this is such a case wherein you can see that more than 10% of the posterior cut was complete and there was a sudden eye movement. You can go ahead with the same patient interface. The only thing is that since you're using a small cone, the diameter of the flap will be smaller than what you might have gotten with a traditional LASIK. So the centration here, especially for astigmatic ablations, is exceedingly important. The next is a suction loss during the anterior cut. Now, the important thing in SMILE here is once this posterior cut is complete, the OBL obscures the visibility of this fixation target, and it is important to caution the patient at this stage not to look for it. You can see secondary to the eye movements, there was a suction loss at the stage of the anterior cap cut. So you can continue in the same setting with same patient interface. Now, there are two schools of thought. Certain surgeons prefer to wait for some time for the OBL to clear, after which they find that the centration is better. I prefer to dock immediately because I feel that the footprints of the patient interface which are there are fresh, and the second dock tends to sit again in the same place as the prior dock. The remaining procedure in the SMILE is as per normal. I'll skip this due to want of time. Now, a word of caution. Sometimes what happens is that during the cap cut, even though there's a slightly unsteady suction, it might still be adequate enough for you to go on with the femtosecond laser delivery. However, in such a case, as you can see here, even though the laser pass can still continue, you can see that there is a superiorly encroaching conjunctiva secondary to an unstable suction. So at this stage, it would actually be better to let go of the foot pedal and stop the suction, because even if the laser pass was to complete, the attenuation of femtosecond here would not give you a corneal side cut. I prefer to stop once a little bit of the anterior cap cut is complete. When you're using the same interface, as is done in these cases, it is important to clean it from any debris which might have been collected. I'm sorry, I think someone else is talking.
Not much of the issue.
In the cul-de-sac,
Can,
it also helps in
can we get the other participants muted?
of the dock, and you can confirm it with the infrared illumination. Another important step that I prefer to do is clear the center for better fixation for the patient, because I don't prefer using forceps. Now, let's provide a contrarian case. This is a similar case in SMILE, wherein you will see that there is an unstable suction at the step of the anterior cap cut. You can see that there's an irregularly enlarging tear film meniscus and the conjunctiva encroaching, but the surgeon goes on to proceed with the entire laser pass. So what we get here is an attenuation of the femtosecond laser superiorly, because of which it cannot penetrate through and there is no side cut. We've published this in 3 eyes, wherein we've used a blade to mechanically open the side cut and then gain access to the area of the interface. The delineation here is a little tricky because obviously the side cut is not as well formed and it's a little smaller than what you would have gotten with the conventional SMILE. However, if one meticulously proceeds and goes ahead to delineate the right planes and subsequently dissect the lenticule, It can be removed without any complications and with optimal visual outcomes. So you can see that the lenticule has been removed. Now, this is another rare case of suction loss that I wanted to share, wherein again, the side cut had not formed. So it was similar in a sense that the conjunctiva was encroaching superiorly, but since we went on with the femtosecond pass, there was no formed side cut. You can see that we're trying to enter with a sharp-tipped instrument. Here we tried opening it mechanically, however, we failed to do so and had no access to the lenticule. So what we did was slightly different. We used the Circle software, pattern D, to convert the cap into a flap, which is akin the traditional flex procedure. We then go on to lineate. It is important to go posterior to the lenticule so as to avoid any false passage creation, and then slowly and meticulously dissect the lenticule and the flap complex from the underlying stroma. One can use a non-tooth forceps to atraumatically hold on to the flap while gently and slowly peeling the lenticule from the undersurface. This takes a little bit of time because there's no counter resistance, but can be done nonetheless. It is important to make sure that the lenticule is removed in toto. You can see that there's a small sliver of tissue which was missing, which is subsequently removed. The interface was washed, the flap reposited, and the patient had an unaided vision of 20/20 on the first postoperative day. So I just wanted to bring about certain take-home points. Unlike LASIK, where the fixation, femtosecond LASIK, where the fixation light goes almost towards the end, here the green blinking light disappears halfway through the procedure. It is important to caution the patient at this stage to not look for it. Getting the centration right is of paramount importance. You can use the infrared illumination to make sure that the dock is right. The redock can be done in the same sitting with the same interface, but one should make sure that the undersurface is cleaned well to remove any debris. And the most important point that I would like to say is that even if the suction is adequate enough to let the pass go on, but you see a superiorly encroaching conjunctiva, please stop the delivery and redock the patient from the anterior cut. Thank you.
Excellent, Dr. Gitansha. Very nice compilation. So, Dr.